Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM, and this is Cardiology Seminars series. In this presentation, we are going to look at left bundle branch block, commonly known as LBBB. So let us begin with the topic. Before I go into the electrocardiographic features of a left bundle branch block, I would like to brush up upon the electrical system of the heart. As we can see, we have the sinus node, and here we have the AB node. From the AB node, we get the right and the left bundle branches. Left bundle branch has the anterior fascicle and the posterior fascicle. In addition to that, the left bundle also has a small septal branch that supplies the proximal portion of the septum. Most often it is a posterior branch, which is the bigger one, which is the larger one, that is blocked, giving a full picture of the complete left bundle branch block, whereas the anterior fascicle is kind of thin and it gets involved more often with the degenerative diseases. As a result, the left anterior hemiblock is more common, but it is of no significant pathological significance. Keeping that in mind, let us look at an electrocardiogram and see what are the features that highlight in the electrocardiogram the presence of a left bundle branch block. Here is a classic example of a left bundle branch block, and here we have a sinus rhythm. Here we have a sinus rhythm. The PR interval is normal, but if you look at the QRS complex in 1 AVL V5 to V6, the QRS complex is wide. It can range anywhere from 110 to 140 milliseconds, and in patients with advanced heart disease, structural heart disease, it could be up to 160 milliseconds. So the first criteria is widening of the QRS complex in 1 AVL V5 to V6. The second criteria is notching of the peak of this R wave. So let's keep that in mind. The third feature we're going to see will be the so-called QS or RS complexes in the anterior leads. Here we have tiny R waves, so this is a RS complex, and they are pretty deep. The QS complexes are very wide compared to the R waves in the lateral chest leads. Now let's look at the STT segments. As you can see in the anterolateral leads, the STT segments are going in the opposite direction of the main QRS complex. So these are called discordant STT changes, or left bundle branch block with reciprocal STT changes. The ST segment is going downslope with an inverted T wave, and that is coming up to reach the baseline. That is characteristic of the left bundle branch block. However, if we see the concordant ST changes, like if the ST segment is going up with the ST elevation, that may suggest an underlying ischemia or even subendocardial infarction. So that's something you need to keep in mind. The next thing is you notice the ST segments in the anterior leads have a reciprocal changes related to what we see in the lateral chest leads. In other words, it is not uncommon to see ST elevation in the anterior leads, which may mimic anterior myocardial infarction, especially with these deep QS complexes. But however, these ST segments are of a concave nature. They're not straight up from the baseline. And if you look at the other features of the left bundle branch block, then you know you are dealing with left bundle branch block than presence of an anterior MI. We'll talk about ischemia and detection of MI in a minute. So these are some of the main features. We generally don't see significant changes in the inferior leads, maybe some ST changes, but the QRS complexes are generally not affected unless we have a left anterior hemiblock. I'm going to show you an example where we're going to have a left axis deviation with widening of the QRS complex in the inferior leads also, but generally with just isolated left anterior hemiblock, the QRS complex is generally less than 120 milliseconds. So looking at these things, so let's move on to an example of a left bundle branch block, now with the left axis deviation and left anterior hemiblocks. So this is almost like minus 60 to minus 80 degrees, and we have a widening of the QRS complex in the inferior leads. Along with that, you can see the ST segments, they have gone up considerably in this lead, and here we have a wide QRS complex with an upright T wave, and here is sort of a biphasic T waves. Here's an example of a left bundle branch block with the left anterior hemiblock and left axis deviation. Now let's look at some of the criteria that you need to kind of memorize, especially when you're taking an exam. The wide QRS complexes are seen in 1 AVL and in the lateral chest leads, as I pointed out to you, along with a notch at the top. The QRS duration can be up to 140 milliseconds, and in patients with structural heart disease, it can be up to 160 milliseconds or longer. And we see the discordant STT changes, which I mentioned to you. We are going to see tiny R waves in the anterior leads with deep S waves. Even though they are called QS complexes, they are actually RS complexes. As we can see, there's a tiny R wave here, and that's a more common finding than to see QS complexes, but they both occur in different cases. So those are some of the features, which highlight the presence of left bundle branch block. And we have heard that if a patient has a left bundle branch block, we cannot diagnose an acute myocardial infarction. We can in fact diagnose an acute myocardial infarction, but by using certain criteria. First of all, if somebody had a normal electrocardiogram to start with, they come to the emergency room with chest pain and they have a new onset of left bundle branch block, that is equivalent to a patient with a myocardial infarction, and they need more aggressive evaluation and management. Now, Scarborough in 1916 described certain EKG criteria that might support myocardial ischemia or infarction in the presence of left bundle branch block. So let's look at some of these criteria. If you see an ST elevation of greater than 1 millimeter in the same direction with the QRS complexes, that's 5 points. Like as I showed you, in a patient with the left bundle branch block, we have the ST depression in the lateral chest leads. If you see an ST elevation in these leads of 1 millimeter, that is a significant 1 point. If you see an ST depression of 1 millimeter in V1, V2, V3, let's go back to that here. If you see ST depression in the anterior leads, that accounts for 3 points. If you see an ST elevation in the opposite direction of the QRS complex, that is 2 points. If you have a score of 3 points or greater, you suspect acute myocardial infarction, and if you have 1 to 2 points, the results are equivocal. But nonetheless, it does help. And if you have fleeting changes, that means changes are different in each day associated with chest pain and maybe some cardiac enzymes, then you know you're dealing with a non-transmural myocardial infarction, and that patient needs more careful attention. Okay, ladies and gentlemen, here is an example of a right bundle branch block. Just to contrast, we see some deep S waves in most of the leads, and we have an RSR prime. You don't see the R, but there's a tiny R wave, RSR prime in the anterior leads, along with the STT changes, and this is a right bundle branch block. In another topic, in the next presentation, I will talk about right bundle branch block. Thank you so much, and please do subscribe to our YouTube channel. I will see you next time.